Medurstand Understanding Medicine.
I am Professor Aziz-ur-Rehman, and I hope that you have watched my earlier videos on calcium related disorders. There were actually four of them. One was on introduction of calcium homeostasis, and I covered different causes of hypercalcemia and hypocalcemia and their treatment approach. Then we had a lecture on hyperparathyroidism, followed by a lecture on hypoparathyroidism, and then there was a lecture on vitamin D deficiency. I hope you have watched all of them and now you are ready for this quiz. As always, this is actually not a test. This is a revision of what we learned earlier, but in the form of a quiz. So let's start. Regarding vitamin D, what statement is not true? Our routine diet has ample amount of vitamin D. Assume that we have balanced diet. We take a portion of vegetable, fruit and meat and poultry and fish, everything in ample quantity, and that diet is rich in vitamin D, or it has got adequate quantity. Exposure to sun leads to production of vitamin D endogenously. Current lab test for vitamin D does not measure the active form. You all know vitamin D, what we take in the form of supplements or in the form of diet, or vitamin D which is produced in our skin is not active. It has to pass through two activation processes. And that very commonly the test is done and patient bring the report showing low vitamin D. Now the question is, what laboratory measure is that the active form or not the active form? Most patients with vitamin D deficiency do not have hypocalcemia. Now I'm talking about those adults who have routine vitamin D tests, or maybe because of fatigue they have this vitamin D assay. It shows low vitamin D, but if you go for the calcium level, that is usually normal. And excess of vitamin D can cause toxicity. Or vitamin D is just a nutrient, it should not cause toxicity. Which one of the five statements is not true? Well, I think we can have an argument here, but I think what we eat normally, most people, the normal diet is not adequate in vitamin D. This is a fact, because vitamin D is not present in most of vegetables, and it is not present in most of the fruits, and it is not present in sufficient quantities in wheat, and that is our staple diet, and it is present in fish and maybe some quantity in milk and eggs. So our normal diet is not sufficient in vitamin D. That is why many people, they have developed deficiency, and that is why people have, that is the reason of having vitamin D deficiency is so common. And the second source is exposure to sun, and our modern living is mostly inside, indoor, so that is why vitamin D is not deficient in many people. Now let's move on to the next quiz. Interpret the following laboratory reports. First is a combination of hypercalcemia and hypophosphatemia. If you remember, I told you that whenever you have some calcium related disorder, it is always a good habit to have calcium and phosphate along with alkaline phosphatase, and if there is any reason to have hyper or hypoproteinemia, then serum protein level also. So these reports are typically interpreted in combination. So if somebody has hypercalcemia and hypophosphatemia, which condition this combination is most consistent with? Primary hyperparathyroidism. because parathyroid has effect on calcium as well as on phosphate, but the effect is opposite. Parathyroid always tries to raise serum calcium and always tries to lower serum phosphate level. So in primary hyperparathyroidism, maybe because of an adenoma in the parathyroid gland, that would increase serum calcium and would reduce phosphate. So this combination is most consistent with primary hyperparathyroidism. Now, second combination is hypocalcemia and hypophosphatemia. Calcium and phosphate both are low. As I just mentioned, parathyroid has opposite effect on these two electrolytes. So since these both are low, perhaps the problem is not related to parathyroid. What it could be? I think this is most consistent with vitamin D deficiency, especially the severe vitamin D deficiency. In vitamin D deficiency, calcium and phosphate both are low, but because of low calcium, there is secondary hyperparathyroidism. Now, this secondary compensatory hyperparathyroidism tries to elevate calcium to make it normal. So as a result, there may be still some hypocalcemia, but hypophosphatemia is more consistent abnormality in severe vitamin D deficiency. In typical case, you would have both hypocalcemia and hypophosphatemia. So this combination is most consistent with vitamin D deficiency. The third possibility is hypocalcemia and hyperphosphatemia. Now, if you concentrate, this is just the opposite of this. This was hypercalcemia, hypophosphatemia. This one is hypocalcemia and hyperphosphatemia. So think of something which is just opposite of this. True hypoparathyroidism. Now, why do I use this word true? Because there are conditions where there is hypoparathyroidism because there is a receptor problem. I believe, yes, in true hypoparathyroidism, this combination will be seen, and those patients who have a receptor problem, again, they would have the same combination. So irrespective of the fact whether it is the problem with the parathyroid glands or the receptors of parathyroid, in both cases you would have hypocalcemia and hyperphosphatemia. The fourth combination is hypocalcemia and hypoproteinemia. You remember, calcium is bound to protein, particularly albumin, but other proteins also. What we measure in the laboratory is the total calcium, including protein bound. But what matters is the one which is free calcium. So this fact is very, very important. So the answer is actually you will make the calculation. You know 1 gram of albumin binds 0.8 milligram of calcium, and the formula was discussed in one of the presentations. So you will make the calculation. If the corrected calcium is low, then it is hypocalcemia. But it is very likely that when you correct the calcium for the protein, then the calcium may actually fall in the normal range. So accordingly, you will make the judgment. So let's move to the next slide now. So this is a case scenario. A patient with decompensated chronic liver disease has following labs. Serum albumin is 1.8 grams per deciliter. Normal, there's a range actually, some 3.5 to 4.5, but let's assume the average of 4 gram. Average of 4 gram, and against that, this patient has 1.8 gram because he has decompensated chronic liver disease. And serum calcium, of course, the total calcium, because it does not specify which type, so it was total calcium and that turned out to be 7.8 milligram per deciliter, and we know the normal range is above this, so this is low. How will you treat this patient's hypocalcemia? So this is the normal range actually. 8.6 to 10.3 is the normal range, and this patient has got 7.8 and he has got chronic liver disease and also have hypoalbuminemia. The albumin is 1.8. How will you treat this patient's hypocalcemia? No treatment required. How can you say this? And I'm just going to prove, although this is apparent hypocalcemia, but when you correct it for hypoproteinemia, you will realize that it is actually within the normal range. So let's do this exercise now. Albumin deficiency in this patient, if the normal is 4 and this patient has got 1.8, the deficiency is 2.2 gram per deciliter, and 1 gram albumin binds 0.8 milligram of calcium. And if we measure calcium, and this low calcium expected due to hypoalbuminemia alone would be 2.2, because there's a deficiency of 2.2 grams, and every gram binds 0.8. So the total amount of albumin which would have been bound to this total amount of calcium which would have been bound to this albumin which is deficient would be 1.76 milligram. So this is the calcium which would be bound to 2.2 grams of albumin. Now if you correct it, now 7.8, which is the value made in this patient, plus 1.76, which would have been bound to this deficient albumin, and if you make correction, the corrected calcium would be 9.56. Now if you compare with the normal range of 8.6 to 10.3, so this falls within the normal range. So this patient does not have hypocalcemia as far as bone function is concerned, as far as nerve conduction is concerned, as far as brain function is concerned. So this patient should not have any clinical manifestation of hypocalcemia, because ionized calcium must be normal. This low calcium is because of hypoalbuminemia. After correction, we have found out that this patient does not have true hypocalcemia, so no correction, no treatment is actually needed. Of course, this patient needs treatment for his liver disease, but no treatment for low calcium. Another case scenario: a patient presents with severe tetany 6 weeks after undergoing total thyroidectomy for papillary thyroid cancer. Now his serum calcium is 7.8 milligram per deciliter, and we have already shown the normal range, and serum phosphate is 7.2 milligram per deciliter, and this is the range is 3.5 to 4.5. So calcium is low, phosphate is high, and this patient recently underwent a total thyroidectomy procedure. You can of course make an idea what must have occurred. You remember one of the complications of total thyroidectomy is inadvertent or unintentional parathyroidectomy. So what is the most likely diagnosis? If this patient was previously healthy, if there was no tetany before undergoing surgery, then I think it would be very safe to assume that this patient has developed hypoparathyroidism as a result of inadvertent parathyroidectomy. This calcium, the tetany is very suggestive of hypocalcemia, and calcium is very low, 7.8, and phosphate is high. Low calcium and high phosphate is typical of primary hypoparathyroidism, and this patient has got primary hypoparathyroidism because the parathyroid tissues have been removed. What further tests may be needed to confirm this theory? I think it's up to you. if this patient was absolutely healthy previously and if this thing developed only after the surgery, I believe there is no other possibility. But if you do want to confirm, you would test his intact parathyroid hormone called parathyroid PTH assays and intact, that is the complete hormone. That should suffice. But in rare cases, maybe cyst maybe scan. Cyst maybe scan is the scan, a radionucleotide scan, which picks up parathyroid gland, whether they are present in their normal location or elsewhere. So if you do a system EB scan, you would not find any tissue showing the function of parathyroid. Mostly, I believe both of them would not be needed because the case scenario itself suggests that this patient has got hypoparathyroidism and you can start with the treatment. But if in a situation you have to confirm, you could have parathyroid assay and you could also have system EB scan. You may also try to do CT scan and ultrasound, but I think in this situation system EB scan should be better. How will you treat this patient? Immediately, if this had happened immediately post-operatively, then probably parathyroid tissue could be reimplanted in subcutaneous tissue. But since this happened 6 weeks after the surgery, so reimplantation of the parathyroid tissue is not a possibility. Now you should treat this patient. How do we treat these patients? I think as a student, you would think that parathormone should be given. There is an analog of parathormone called Netpara, but that is available in the world, but it's very, very expensive. Now, traditionally, what we have been doing is to give calcium carbonate and active vitamin D. The theory is to give vitamin D in large quantity to produce a state of hypervitaminosis D. And we give active vitamin D. Why? Because if we give normal vitamin D, that would not be activated into its active form because of the absence of parathyroid hormone. So we will give active vitamin D, calcitrol or calcidol, and along with that large amount of calcium carbonate is given. So aim is to build up his serum calcium by giving large amount of calcium carbonate and vitamin D to produce a state of hypervitaminosis D, which one of the complications of hypervitaminosis D is hypercalcemia. So we are actually creating a state where the low calcium will be raised to the normal calcium level. So this is the strategy. Calcium carbonate has the additional function of binding with phosphate. Now once we administer calcium carbonate orally with meal, it would bind phosphate and prevent hyperphosphatemia. And hyperphosphatemia is responsible for secondary hyperparathyroidism, which can lead to bone disease. So that is why we give calcium carbonate, not just any form of calcium. So this is the theory, and of course we will not be able to exactly normalize the biochemistry of this person, but by raising calcium and by keeping phosphate low, we can certainly help this patient. Now this is another question, brain ganglia, basal ganglia. The brain basal ganglia calcification may be seen in chronic calcium related disorders. Which of the following is most associated with this complication? I'm going to list 4 or 5 possibilities. You have to pick up the condition where you see basal ganglia calcification most frequently. Sarcoidosis, hyperparathyroidism. In hyperparathyroidism, there would be hypercalcemia. Secondary hyperparathyroidism. And secondary hyperparathyroidism is actually secondary to a chronic hypocalcemic state like kidney failure. Hypoparathyroidism. In hypoparathyroidism, calcium is low, but phosphate is high. And the fifth possibility is malignancy associated hypercalcemia. Many malignancies through various mechanisms can cause hypercalcemia. So which of these five possibilities which can disturb calcium uh, can may be associated with basal ganglia calcification? Hypoparathyroidism. Now this is a little tricky because mostly one would think that in hyperparathyroidism there is hypercalcemia, and in hypercalcemic state perhaps there will be possibility of calcium deposition in the tissue. Uh, that can happen actually in hyperparathyroidism also, but it happens more commonly in hypoparathyroidism because what matters is actually calcium phosphate product. In this, calcium goes up, phosphate goes down. In this condition, calcium goes down and phosphate goes up. In both, the product is affected, and in this condition, it is more likely that the calcium phosphate product would go above a threshold level where basal ganglia calcification can occur. So this is the correct answer. What is not true about parathyroid adenoma? It may be a part of multiple endocrine neoplasia syndrome, and you are familiar with this term. There are some people who, due to some genetic predisposition or sporadically because of with family history, without family history, they may develop multiple endocrine neoplasia, and this is abbreviated as MEN. Actually, there are various types of MEN, and just consider it MEN in general. And the second is it may be associated with other neuroendocrine tumors like pheochromocytoma, some lipoma, uh, pituitary tumors. So I think that is the second uh, question. After the diagnosis, surgical excision should be carried out straight away. If you have a case of hypercalcemia and you suspect parathyroid tumor, you do ultrasound CT, you find a tumor, and you straight away send the patient to the surgeon. Is that the right approach, or you need to ponder a little more and maybe do some more tests? It may be situated in some ectopic place. Normally, parathyroid glands are present in the just behind the thyroid gland, and that is where the tumor also arises. But the question says that the parathyroid tumor can actually arise from some ectopic place like lower part of the neck or mediastinum. And parathyroid adenomas are mostly malignant. What is not true about parathyroid adenoma? Parathyroid adenomas are mostly malignant. This is not true. They are mostly benign. They could be malignant, but mostly they are benign. All other statements are correct. Answer following questions. What are the different forms of calcium present in the blood? Calcium is present in the blood in the form of free calcium, which is called ionized calcium. That is about 50% of total calcium, and that is what matters. Okay, and then remaining 50% is further divided. 35% of the remaining 50%, and the 35% of the total is bound to albumin. That is not free, but that is in equilibrium with the free calcium. So that is available. Once free calcium is consumed, the one bound to albumin becomes available. And 15% of the total calcium available in the blood may be actually bound to other proteins. This is important because when we measure total calcium, when we measure serum calcium, we measure total calcium. But the changes in albumin and protein level can affect our total calcium, and not the free calcium, which is important for function. So we have to make a correction whenever we confront with the situation with hyper or hypoproteinemia. So these are the three forms: free, ionized, bound to albumin, and bound to other proteins. This is about 50%, this is about 35%, this is about 15%. Why calcium carbonate must be given with meal in patients with hypoparathyroidism? Must be given. Of course, it may be given otherwise also, but it works best if given with meal. If this is just as a source of calcium, perhaps it could be given any time, but it has to be given with meal because it has got a dual function. One of the function of calcium carbonate is to provide calcium. These patients have hypocalcemia. But another important function, perhaps more important function, is to bind phosphate. Patients with hypoparathyroidism are advised to take minimum amount of phosphate, but some phosphate will of course be present in diet. So that phosphate, when somebody takes calcium carbonate, the phosphate in the diet binds to calcium, and then calcium phosphate is excreted in the stool. So that is how with the calcium carbonate we actually prevent absorption of phosphate to minimize the chances of hyperphosphatemia and hyperparathyroidism and chronic bone loss. So this is the philosophy. Calcium carbonate must always be given with meal, and typically it's a large dose, 2 to 3 to 4 tablets with every meal. Why system EB scan is indicated in people suspected of having primary hyperparathyroidism and negative ultrasound or CT of the neck. If somebody has primary hyperparathyroidism, and I think our first line of test is ultrasound and CT, that will usually demonstrate hyperplasia or adenoma or tumor of one or more of the parathyroid gland. Suppose ultrasound and CT of the neck, either or both of them were done and no parathyroid tissue was found. So how do we determine the presence of parathyroid tissue other than this normal position? That is with the system EB scan, because system EB scan will pick up any parathyroid tissue in the mediastinum or anywhere else in the body, and if the parathyroid tumor is present somewhere else, then if the parathyroid gland is present somewhere else, then the tumor will also of course arise from that tissue, and the tumor will also be in some other place. We are still continuing with this exercise of answer the following question. What is the rationale of giving very high dose of vitamin D in cases of hypoparathyroidism? Normally we give vitamin D just to normalize one's vitamin D level. The normal level is like 30 to 100. If one's vitamin D is above 150, then there is a chance of vitamin D intoxication. But in these patients, we actually intentionally give high dose of vitamin D. What is the rationale? This was actually discussed in this quiz. The intention is to create a state of hypervitaminosis D. Ideally, in these patients, we should give parathyroid hormone. Parathyroid hormone, net para, is very, very expensive, and for most people it is not available, at least in our country. And so we give vitamin D and we exploit its side effect of causing hypercalcemia to correct actually existing hypocalcemia. Which of the two is a better form of calcium for intravenous use in severe hypocalcemic states? In one of the lectures we also discussed hypocalcemia, and if somebody has got hypocalcemia and has tetany or maybe convulsions, you have to correct serum calcium correctly. Now we have two forms available. One is calcium chloride, The other is calcium gluconate. These two are available for intravenous use. Which one you think would be better? In an emergency situation where there is hypocalcemic tetany or convulsions. In other words, I'm asking which one works fast. Calcium chloride, because calcium chloride is actually free calcium. The moment you inject it, serum calcium will start rising. Calcium gluconate is considered to be a safer option when you want to give calcium, not as an emergency but otherwise, because calcium gluconate, the gluconate part has to be removed in the liver and calcium will be available slowly. It will take a lot of time to normalize serum calcium, but in this situation we want quick and fast result, so that is why calcium chloride will be given. Normally calcium chloride is not given as a replacement of calcium because a quick administration can cause hypercalcemia. So there are pros and cons of each preparation, but in this scenario I guess calcium chloride would cause will be better because it will normalize calcium level relatively quickly. Which of the following is not a recognized feature of hypocalcemia? Tetany, exaggerated deep tendon reflexes, stunted growth if it is chronic and it develops in the growing age, bleeding, since calcium is required for clotting, all clotting steps they require calcium, so maybe one can consider hypocalcemia as cause of bleeding disorder, and lethargy. I think my answer would be bleeding, because although it's a absolute fact that many clotting factors they need calcium to show their action. So theoretically, deficiency of calcium can cause bleeding disorder because clotting factor will not work properly. But actually, they need extremely low amount of calcium. And before one would develop that degree of hypocalcemia, there would be other manifestation like seizures and maybe there's death before one develops hypocalcemia of the severity which may cause bleeding disorder. So based on that theory, I guess this statement is not a recognized feature. If somebody presents with bleeding disorder, then you need to consider other possibilities. What is the precise function of calcium carbonate therapy in hypoparathyroidism? I think we'll quickly, it correct hypocalcemia because it is calcium, and it is given to prevent hyperphosphatemia. It binds with phosphate, and to prevent secondary hyperparathyroidism. Once hyperphosphatemia is prevented, then secondary hyperparathyroidism is also prevented because it is the phosphate which causes secondary hyperparathyroidism. And all of 1, 2, 3, 1, 2, 3, all three are correct, or none of the 1, 2, 3 are correct. This is very simple, straightforward. I think all 1, 2, 3 are correct. Now remember, this is not the test, this is the revision. That's why I'm explaining these concepts because they were actually discussed in my lectures, but I'm just revising them because I want you to take that message home, and the purpose of this academic activity is actually fulfilled. Which of the following is useful for the treatment of hypercalcemia associated with malignancies? Bisphosphonates, bisphosphonates, they bind calcium and they deposit calcium in the bone. Calcitonin, this is the hormone which has effect just opposite of parathyroid. It would lower calcium and it would raise phosphate. And bisphosphonates, because it binds calcium and take it to the bone, it would also lower serum calcium. intravenous phosphate, they can immediately phosphate bind with calcium and they make a precipitate and it lowers serum calcium rather quickly. Forced diuresis, that means intravenous saline is given and furosemide is given to remove extra fluid we're giving. This is called forced diuresis. All are true. So in this kind of question, if you can figure out that at least one or two is correct, then you can say this all are true. I think the answer is all are true. All these things are used in hypercalcemic state. Hypercalcemia is a true medical emergency. Sometimes it could cause death also. So if you confront a patient with severe hypercalcemia and especially associated malignancy, you should do this stuff. I think the first thing to do is forced diuresis. Maybe then you can give intravenous phosphate, which is very fast acting, but it has got only short-lived effect. Calcitonin and bisphosphonate would have more durable effect. Other things like dialysis and steroids and anti-cancer therapy, they would also be needed. Thank you very much. This is Professor Aziz-ur-Rehman from Medurstand. I hope this activity was useful and you enjoyed it. Please let me know and I'm really looking forward to see you in my next series of lectures which will be on other subjects. I hope this activity on calcium related disorders, hypercalcemia, hypocalcemia, hypoparathyroidism, hyperparathyroidism and vitamin D deficiency followed by this quiz was useful. Please do let me know and give me your feedback. Thank you very much. Professor Aziz-ur-Rehman from Medurstand.